Hi all. Today's lecture is about white blood cell disorders. We'll look into uh, details about how the white blood cells are formed, what are the different diseases affecting them, and a look at what is the difference between leukemia and lymphoma. The disorders of white blood cells can be classified in different ways. Today we'll look at a classification which is given in Robbins. And I am Major Nabil, your new pathology assistant professor. So, what exactly happens in hematopoiesis? All the blood cells we know, like WBCs, RBCs, platelets, everything is formed from a common progenitor or common ancestor, whatever you can call. See, this hematopoietic stem cell has got two very important properties. One is self-renewal. This arrow depicts self-renewal. So it keeps the hematopoietic stem cell pool at a finite number, so that it is not exhausted. And the other property is pluripotency, which means it can differentiate into almost any of the hematopoietic cell. Now the hematopoietic stem cell will become multipotent progenitor. From it will go into a committed line. Can be lymphopoiesis or myelopoiesis. And lymphopoiesis will end up in forming natural killer cell, B cell or T cell. Then myelopoiesis will end in neutrophil, monocyte, eosinophil, basophil. The self-renewal capacity decreases as we go down, and the ability to replicate or cell division increases as we go down. The hematopoietic malignancies, most of these tumors occur either due to a block in any of these things, like if there is a block here and these cells accumulate, forms a malignancy, or say there are growth factors which help these cells go into different committed precursors or different lineages, and if that growth factor dependency is gone, that cell will be able to multiply on its own. So details about that will be discussed under each of these malignancies. Now that we have an overview about hematopoiesis, let's see how these diseases of white blood cells are classified. Look, WBCs can increase in number or decrease in number. Increases leukocytosis, decreases leukopenia. An increase in number can be due to malignancies or just a reactive process. Okay. So here you can see I've written reactive proliferation of WBC and lymph nodes. we'll see why it is like that. And the neoplastic proliferation is divided into two, lymphoid or myeloid neoplasms. And of course there are a lot of lymphoid neoplasms. This is the WHO classification. We'll go into details of each. And myeloid neoplasms, you would have heard of them, like AML. We'll go into the details later. Let's first look at leukopenia or reduction in WBCs. Like in a clinical scenario, most common leukopenia is actually neutropenia or reduction of neutrophils. So if the neutrophil count goes below 1500, infections can occur, and if it goes below 500, serious infections can occur. You can go through it. All these infections are beyond the scope of this lecture, but we'll go into what are the causes of neutropenia. There are congenital causes, like all these Causeman syndrome, cyclic neutropenia, etc. are congenital or genetic causes of neutropenia, but the acquired ones are the most common. To lymphopenia, probably the most common cause would be HIV, and of course steroids which doctors give, or any other cause of increased glucocorticoids in the body. Cytotoxic drugs, of course, anti-cancer drugs, malnutrition, other viral infections. When it comes to leukocytosis or increase in WBC number of WBCs, different mechanisms can cause leukocytosis. Like imagine WBCs are of course produced in the bone marrow. So if because of some reason there is increased marrow production of WBCs, most common reasons are chronic inflammation, then paraneoplastic, like that means if there is some malignancy somewhere else, and because of that there is a reactive proliferation. Then myeloproliferative neoplasms, will come to that later. Or there is increased release of WBCs from already produced marrow stores. This is probably the most common cause of leukocytosis. Like if there is an infection, to fight the infection, whatever WBCs are required are released from the marrow. These WBCs are like preformed ones. Then comes decreased margination. What exactly is decreased margination? You like when the WBCs are flowing through blood vessels, most of the neutrophils are flow through the blood vessel and through the periphery of the blood vessel, and most of these RBCs go through the middle. So that is called margination. So decreased margination means when there is when you do exercise, or especially when there is catecholamine release in the body, these cells come and flow through the middle. So when we take the blood out, more WBCs come in the sample. Then decreased extravasation into tissues, again due to steroids. So when less of WBCs extravasate into tissues, more WBCs are present in the blood cells. What are the causes of leukocytosis? See, neutrophilic leukocytosis is probably the most common leukocytosis out there, and most common cause is bacterial infections only. There are other causes like burns, MI, other injury caused to tissues and all. Eosinophilia, most commonly due to allergies, asthma, parasitic infections, very important. Occasionally hematological malignancies or autoimmune diseases. Basophilia is actually very rare. It's almost always due to a hematological malignancy, unless otherwise proved. Monocytosis, again we know monocytosis occur due in chronic infections like TB in India, in other places in the Western world probably ulcerative colitis and all common causes. And coming to lymphocytosis, almost always accompanies monocytosis in many diseases like TB, brucellosis, or other viral infections. Coming to reactive proliferation of WBC and lymph nodes. It is actually difficult to differentiate, or not differentiate, you can say it is difficult to separate WBCs in the blood from WBCs in the lymph node. It is all like they go from bloodstream into the lymph node, from the lymph node to the bloodstream, etc. So reactive leukocytosis, we have seen many causes already in the previous slide. These are all except the malignant ones, all are causes of reactive leukocytosis: bacterial infection, allergy, chronic infections, etc. Okay. Coming to reactive lymphadenitis. Yeah, normal lymph node looks like this, and in reactive follicular hyperplasia, which is the most common cause of lymph node enlargement, looks like this. It usually occurs when there is a bacteria in this. Say, imagine this is a lymph node of the axilla, and there is a bacteria infection of the finger on a wound, by an infected wound or something. So the corresponding draining nodes will swell up because of reactive follicular hyperplasia. I'll not go into details of how it occurs and all, like that will be discussed in an entirely different chapter, or I guess that is already been discussed. Yeah. So, like, at this point, I just want you guys to do some homework. Sorry. Sorry, my baby is crying. I want you to do some homework regarding why are white blood cells called so. I'll ask you about this in the next class. And what is HLH? It's given in the textbook. Now coming to neoplastic proliferation of WBCs, white cells. These three this is a general overview about the pathogenesis of white cell neoplasms. One of the causes is increased self-renewal. Mutations in PML, RARA, KMT2A, etc. cause that. So there is no block on self-renewal, and it is not correct when you say no block on. The self-renewal is increased. Then there is decreased apoptosis. BCL2 is related to apoptosis. So when BCL2 is not there, there will not be any apoptosis. So cells keep on dividing. Then if there is any increase in pro-growth mutations or increase, it causes increased cell division. Okay, these are things which you've gone through in neoplasia. Look, we have already seen the myeloid stem cell becomes myeloblasts and white blood cells, and there is lymphoid stem cell finally becomes lymphocytes. So these are myeloid neoplasms, these are lymphoid neoplasms. We'll go into lymphoid neoplasms. Lymphoid neoplasms are classified according to their, can say, stage of development, which we already saw that in hematopoiesis. So one is precursor B cell neoplasm, then is precursor T cell neoplasm. Okay. Those are like immature neoplasms. ALL, acute lymphoblastic leukemia, lymphoma. Then peripheral B cell neoplasms. Then peripheral T cell, NK cell neoplasm, and Hodgkin's lymphoma. I want you guys to think of this as neoplasms occurring at different stages of hematopoiesis. Okay, which we saw earlier, like a precursor or immature neoplasm. Then as the development continues, becomes peripheral neoplasm, peripheral B cell or T cell or NK cell, like that. And Hodgkin's lymphomas are slightly different. We'll go through it later. Now, this malignant lymphoproliferative disorders can be divided into immature and mature, like we saw on the table. So the immature one, whether T or B, both are called ALLs. This is probably the most common hematopoietic neoplasm in children, acute lymphoblastic leukemia, lymphoma. And as the cells progress or differentiate, mature, they can cause lymphoid leukemias or lymphomas. Now here comes, like, we'll have a doubt, like, what is the difference between this term called leukemia and lymphoma? In simple terms, leukemia means something affecting blood and bone marrow, and lymphoma means something affecting lymph nodes and spleen, etc. So lymphomas can be B cell or T cell. B cell lymphomas are more common. T cell lymphomas are quite rare. Now, what is the difference between Hodgkin and non-Hodgkin lymphoma? Like, there is difference in clinical presentation and microscopic features of both. Hodgkin lymphoma is more of a it occurs in a particular group of lymph nodes. Then they have a predictable contiguous spread, and extranodal involvement is rare. Almost always Hodgkin's lymphomas almost always occur in lymph nodes only. Now, non-Hodgkin's lymphomas more like disseminated. It can occur outside lymph nodes. Then skin can be involved, and it can occur at multiple sites, above and below diaphragm, all over the body, like that. Here you can see the difference between a B cell neoplasm and a T cell neoplasm. Okay. These are all non-Hodgkin lymphoma except this Hodgkin lymphoma. These are all non-Hodgkin lymphomas. So, as you can see, Hodgkin lymphoma arises from a germinal center cell. Okay. Now here, see, B cells, as we all know, are derived from bone marrow, and T cells are from the thymus. Now, when early precursors of B cells become neoplastic, called precursor B cell lymphoma, or ALL, basically, acute lymphoblastic leukemia, lymphoma. Now, AL is called lymphoma leukemia because it can present in lymph nodes and blood. So the distinction is, can say, blurred. Then once it starts dividing, small cell lymphoma, chronic lymphoma, chronic lymphocytic lymphoma, multiple myeloma, can say, is a different type of, it's almost a different entity because it is a neoplasm of plasma cells. We'll come to that later. Then T cell lymphomas arise from T cells. This is ALL itself, TALL, and then peripheral lymphomas. I guess you got an overview about lymphomas. Like when we go into each of these lymphomas, you'll get a better idea. Now, as we have seen, lymphoid neoplasms can be divided into peripheral, precursor, and Hodgkin lymphoma. Among this, we'll go through only precursor B or T cell lymphomas, neoplasms, which is ALL basically. This one. Acute lymphoblastic leukemia. It is mostly B cell or BALL, mostly seen in children and more common in males. But how do they present? Usually a kid presents with anemia, infections due to neutropenia, and thrombocytopenia, maybe bone pains, and lymphadenopathy, hepatosplenomegaly, etc. Why anemia, neutropenia, etc.? Because bone marrow will be filled with these neoplastic cells, and other normal hematopoiesis will suffer. Okay, case scenario. It's a 4-year-old male with fever for 2 months, sore throat for a week, pallor, which is anemia, cervical lymphadenopathy, petechial hemorrhages because of thrombocytopenia, hepatosplenomegaly. Another important thing is TALL can present as a mediastinal mass, and CNS involvement is pretty common in BAL, B cell ALL. Testicular involvement can occur in ALL. What does the pathologist see? How is it diagnosed? Pathologist, there may be, he can see probably anemia. Anemia is usually present. There will be marked elevation of WBCs, and more than, like, to call something leukemia, there should be at least 20% blasts in peripheral blood. Call something acute leukemia. Sorry, not leukemia. Call something acute leukemia. 20% blasts in peripheral blood or bone marrow. They can, and these 20% of blasts in ALL, these blasts will be lymphoblasts. And usually there is thrombocytopenia. Yeah. Look, these are your blasts. These are lymphoblasts. Why do I call them lymphoblasts? Because, see, they are large cells with very less cytoplasm and large nuclei with open chromatin, and there are some nucleoli but not very conspicuous. This chart just shows the immunological markers. These are commonly used in the diagnosis. Like, these are CD22 TDT positive, CD19 CD10 positive. Okay, No, prognostic factors in ALL. Like, a broad overview would be, it is ALL is worse in very young and very old, very young children and children more than 10 years old. Males have an unfavorable prognosis because of testicular involvement, and if the total count is very high or there is hypodiploidy, or if it's not responding to treatment, obviously. We'll go through peripheral basal neoplasms in the next lecture. Thank you.